So I'm going to be talking about the difficult issue really of suicide today. And if we're looking at kind of exemplars for something that we in the North should be kind of worried about, I think this is one of them. As well as an academic at the University of Manchester. I'm also a kind of clinician. I've been thinking about suicide, researching suicide in one form or another for 25 or kind of 30 years really. So much of our research is focused on what we kind of do about it. So you'll get lots of numbers, a bit of kind of epidemiology. I'll talk for probably about kind of 30 minutes or so, maybe a bit less, maybe a little bit more, but leaving plenty of time for discussion. So let's just get this working. So I'm hoping I once did a talk where no one could hear me or see my slides, but I'm hoping Dan will let me know if I go offline or what have you. Otherwise, I will just carry on regardless. So this is what I'll talk about over the next 25, 30 minutes. I'll start with some suicide data. We always start with kind of data, but not forgetting that behind all these big numbers that I'm going to show you are individual tragedies, individual lives with friends, families, sadly, kind of left behind. I'll then talk a little bit about inequalities, because I think that's really pertinent both to suicide prevention, but also mental health more generally. Then think about what we know about preventing suicide, what's some of the evidence base, and that'll be more general than the North. It'll be what we know about suicide in general, the evidence base for preventing it. And then most important of all, perhaps, is implementing what we know, because we, researchers like me, we generate lots of research. It's of little use unless we implement it into clinical services. And that's where groups like your one, I think, particularly come in. Okay, so let's start with some suicide data. So here's the latest suicide data from the Office of the National Statistics from last year. And the headline figure here is, in 2024, nearly 6,000 suicides registered in England. This is registered. This is when they kind of appear on the official statistics rather than when they occurred. I'll talk a little bit more about that later. But it's a lot of people, and that's a rate of about 11 per 100,000 per year. So nearly 6,000 deaths per year. But they aren't uniformly distributed. So this is from our latest report on the Confidential Enquiry, and basically in terms of regions, it's the northeast and the northwest that kind of vie for, they're the places with the highest, they're the regions with the highest suicide rates over about a past decade, and Yorkshire and Humber aren't that far behind. So there's a kind of, if you like, an unequal distribution of suicide, with the northwest and northeast the highest, and London consistently is the place with the lowest suicide rates. That's pretty stark, but actually you can express it in even more kind of stark ways, really. And I think this is really important. So this is using a different measure, if you like, for suicide. It's not just suicide rates. It's thinking about a calculation of years of life lost. So this is taking into account people sadly losing their lives, dying, but when they die as well, to make a calculation of years of life lost. And when you look at suicide through this lens, if you like, the kind of disparities, the differences are even wider. So we're looking in terms of years of life lost to suicide. So someone dies by suicide, well, how much life expectancy have they lost? So it's nearly 50 years in the northeast, and it's not far behind in Yorkshire and Humber and the northwest. So 40 to 50 years of life lost. So I think this is really important, and it's over double the years of life lost in the London region to suicide. So we've got kind of wide disparities in suicide rates, even wider disparities in terms of years of life lost. The other thing, of course, to look at is suicide trends. Now, long-term trends in the UK have been down, which is good news, but there have been recent fluctuations, quite often related to economic factors. But This is just data now taken from OHID, of Health Improvement and Disparities, just the official data, and it's just one of the regions in the north, the northwest. But this is the same in Yorkshire and Humber, and it's the same in the northeast. That what we're seeing is if you like, a divergent trend. So trends in England, what's happening in much of the north is that rates are rising faster in the north than they are in the rest of England. There's a bit of an artifact on this graph. So this you're thinking, oh my gosh, that's a huge rise in the northwest in the latest recording year. That's probably a result of those deaths being registered more quickly. So there's a delay between when a death occurs, when it gets kind of registered. And this is actually probably this last year is a function of the way the statistics are collected. And it's an illustration that even for something like suicide data, the trends aren't straightforward. You need to interpret them. But in general, northwest, northeast, in Yorkshire and Humber, they're divergent trends. So rates are rising faster here than they are elsewhere. For other measures of suicide as well that we collect, so this is patient suicide now as part of the confidential inquiry. So this is taking into account people who are in contact with mental health services, the levels of volume of people coming through the mental health services, and the suicide rate a little higher in the north. But in terms of clinical services, the level of challenge is similar. But the other thing we can do with the clinical data that you can't do with the general population data, that's about a quarter of all people in contact with mental health services. But the other thing we have as part of the inquiry is detailed data on who those people are. So what we can do then is, if we know who the people are, we can look at similarities and differences from the rest of the country. And this starts to give us a clue about how we might tweak prevention in the north compared to elsewhere. And I think nothing on this slide is going to be a kind of surprise to you. So in terms of social adversity, we've got a higher burden of that in the north compared with elsewhere, and as a result, people who die by suicide are more likely to have characteristics like living alone, being on long-term sick, or economically inactive. Other measures of, if you like, social adversity. So more patients who've died by suicide, kind of history of violence, both perpetrating violence and being the recipients of violence. Self-harm, so people hurting themselves by taking tablets or hurting themselves in other ways, the most important risk factor for suicide probably, and more common in the north than elsewhere. And alcohol and drug dependence as well, and this a greater proportion of people aged 25 to 44 than in other parts of the country. So it gives you a clue of some of the things, certainly from a clinical perspective, some of the areas of focus, or some of the things we might tweak. So to talk a little bit about suicide data, I want to talk next about inequalities, because inequalities is probably what underlies some of these differences in rates. So here's the differences in rates. Remember here the dark colours are higher suicide rates, and here's a map of something called buoyancy. So it's a measure developed by researchers, is geographically matched. Geographically explored suicide rates over many years, Peter Congdon in London. And this is a buoyancy score. So it's a measure of kind of economic buoyancy, if you like, taking into account employment, taking into account productivity, taking into account other factors. It's almost the kind of mirror image. So, the economic buoyancy, the economic kind of, if you like, positive economic factors are higher in London and the southeast. That's not going to surprise you. We've got this kind of pocket here in the north, but in general, the buoyancy is much lower, and it's almost a kind of mirror image of this map, which tells us that some of the drivers of suicide, some of the most important drivers of suicide, are economic, and obviously that's pertinent when we're thinking about the north versus everywhere else. And those inequalities don't just affect the incidence of suicide, don't just affect how common suicide is or the suicide rates. they also affect access to healthcare. So there are a few slides here provided by my colleague, Professor Roger Webber, who I think is actually on the call as well. So thanks for these slides, Roger. But here's a study we were both involved in a little while ago. And this is self-harm now. So it's not suicide, it's self-harm, but the two are related. And what you see is what you might expect. So these are numbers of episodes of self-harm according to how deprived the area, socio-demographically deprived an area is where people live. So these are quintiles. So if there was no relationship between self-harm and deprivation, basically all of these bars would be the same height. But in fact, what you see is a stepwise relationship. So the people who live in the most deprived areas have the highest rates, have the highest numbers of self-harm episodes. It's what you'd expect. The link between deprivation, mental ill health, self-harm and suicide is what you expect. Perhaps what you might not expect, though, is access to care. So this is the percentage of people referred to specialist mental health services by deprivation quintile. And what you see here is people who live in the most deprived areas have the highest rates of self-harm, but the lowest proportion of them are referred to mental health services. So, it's an example, those of you who work in public health, the Tudor Hart, the inverse care law. So the people most at need in health are often people with the least access to services. So the inequalities affect the rate of suicide, rates of self-harm, but also access to care. The other thing about social inequalities is they can be mitigated, but the effects can also be long-lasting. Okay, and I put on this fairly complicated slide, but it's such a elegant and wonderful piece of work by my colleague Pearl Mark, and I'll talk you through it. Okay, so what we're looking at here, it's Danish data, it's not UK data. What we're looking at here is we're looking at, if you like, the deprivation level of kids and the deprivation level they were born into, and if you like, the effects of, if you like, social mobility through childhood and what that does to self-harm rates. What you see here is these are kids born under the most deprived circumstances. And if you're born under the most deprived circumstances and you stay in those most deprived circumstances, you've got the highest rate of self-harm in late childhood, early adulthood. If you manage to kind of move to a higher socioeconomic status, your levels of self-harm come down. So these people here, the ones that were born under the most deprived circumstances but ended up in the most affluent circumstances. And what you see is that attenuates the risk of self-harm, which is good. So social mobility, can mitigate some of the effects of early adversities. What's worrying about this graph for me, though, is even when you mitigate things, so these are people who have ended up in the most affluent circumstances, this bar is higher than many of the bars in the kids that are constantly lived in the most, if you like, affluent circumstances. So those who were born kind of affluent and stayed affluent, this is still higher. So there's this legacy effect. So yes, you can mitigate some of this effect of inequality by early action, but some of the effects are long lasting. And it's not just suicide deaths. I'm talking about suicide deaths here, but this is a study Roger, Christine Camacho and others were involved in a little while ago. I don't particularly like this this labelling, as Roger knows, but the point here is not just suicide, alcohol, drug deaths and other things cluster in the same way. Many of the risk factors are the same, and in fact many of the mitigating factors, many of the things you can do about it are similar as well. So not just suicide. So I've talked a little bit about suicide data and the variations. I've talked a bit about inequalities and how it's not just the rates, it's access to care, and how the effects of inequalities can be mitigated, but some of those are legacy effects that we really need to be thinking about. Just thinking a bit more broadly now, and some of you I know will be very familiar with this, it's just what do we know? What do we know about preventing suicide? What's some of the research and evidence base? So here's the World Health Organization's take on prevention. That's very good, a nice framework. And there's some things on here I'm not really going to be talking about today. Some, if you want to prevent suicide, you can do, lots of public health things like limit access to means of suicide. And that's because although, sometimes sadly people build up to hurting themselves or ending their lives, the final decision is sometimes quite a sudden one. So if you limit access to means, people don't inevitably change to another method of suicide. Often you prevent death. So this is things like access points on bridges. It's things like limiting pack sizes of analgesics in this country, limiting access to pesticides more widely. So it's a very powerful suicide prevention measure. I'm not going to be talking about that today. I'm not going to really talk too much about the media and suicide prevention, although we know media reporting that's less than helpful, that might focus on method or might glamorize things, can actually propagate suicide. So these are things really important, but I'm not really going to be talking about today in the context of, the North, or in context of inequalities, because these are things that, if you like, apply across the board, across the country. But there is one thing I do want to talk about, which I think is pertinent. It's the spending review. Remember, this week you won't have failed to spot that one. But it's this relationship. It's back to the economy, the relationship between economic turmoil and suicide. And this has been demonstrated over many, many years. One of the things economists will tell you, though, is not every period of economic turmoil is the same. All recessions are a bit different. So we do need to kind of bear that in mind. And, the current economic pressures are different, for example, to the recession we had in 2000 and in the 2000s and teens. So they're different, but there are some kind of lessons there. Economic turmoil is implicated in suicide, but we also know what to do about it. So it's a paper from my colleague Mark Senior in Canada. So, here are some of the things you can do about it. So, one of the really important things is to collect data and research. So when there's a period of economic turmoil coming up, measuring the mental health of your population, measuring suicide and self-harm rates. So that's really important. Thinking about, what the health and social care response is. So, as more people come through with economic or financial stress as a precipitant or a perpetuating or a contributing factor for the mental health presentation, having staff that are clued up. We can't, they're not going to be kind of benefits workers or anything like that, but, certainly be able to signpost people, certainly be aware of the link between economic turmoil and poor mental health. Stuff for the media, so avoiding kind of sensationalized reporting of what economic turmoil might do to mental health. Public health. There's public health messaging, making sure there's positive messaging, not just negative messaging about the effects of potential mental health downturns, and messages about the mitigation effects as well. But the thing I really wanted to talk about today, and probably the most powerful way of mitigating the adverse effects of economic turmoil or mental health on suicide, are economic measures. So, there's this idea that when unemployment increases, suicide rates increase. That's been shown, a number of times. But one of the other really interesting things is that can be mitigated. So there's an interesting bit of research based on the really the kind of depression as more than a recession last time round, which showed that yes, recessions worsen mental health, they increase suicide rates, but actually those effects could be mitigated and were mitigated in countries which increased welfare spending at a time of economic adversity rather than adopted a kind of austerity measure. Again, a kind of more a kind of, I'm trying to, these are my wishes for the kind of spending review rather than any hopes. And, colleagues in Oxford have come up, this is David Stuckler in Oxford, come up with this very pithy phrase, which I can't claim credit for, which is that recessions can hurt. So the recessions can harm mental health, but it's actually the policy response, the austerity that actually kills. And by increasing welfare spending, you can mitigate some of that effect. And some of the international evidence is really interesting on this. So this is Diane Machado, colleague from Brazil, and did this fantastic kind of naturalistic exploration of a program where they gave people cash. So it's a conditional cash transfer program. So it isn't, welfare payments in the traditional sense. It's conditional cash. It's conditional. So it's conditional. Families would get the measures, they would get the money if they signed up to things like childhood immunisations, they got the kids to school, prenatal screening, that kind of thing. So it was conditional. But in that experimental study, there's kind of lower rate of suicide. So, this is a low middle income country context, but it's a pretty stark kind of reminder of the links between economic factors and suicide, and perhaps some of the potential interventions. Moving away from cash, moving away from the economy into clinical services. I mean, when we're thinking about what we do about prevention, we've got some stuff to help us. So obviously, Dan's highlighted my role on the NICE guidelines, and you could argue I'm biased when it comes to the utility of clinical guidelines. But we have clinical guidelines, we have a suicide prevention strategy. Our latest clinical guidelines on self-harm came up in 2022. This is our new suicide prevention strategy from England for 2023. Just summarising the whole of the NICE guidance. So, it's kind of 3 years of my life in kind of in the briefest possible terms. What are some of the important things when we're looking at self-harm? Remember, self-harm is the most important risk factor of suicide. Half of people who die by suicide have a risk of self-harm, and in the year after someone self-harms, they have a risk of suicide about 30 times greater than the general population. So a key thing to intervene with. One thing is making sure people get assessed, get a proper assessment when they present to clinical services. We still know only about half of people get a proper assessment when they present to clinical services. So assessment's really important. Aftercare is very important, and swift aftercare. So getting in there within 72 hours of a presentation. We know that people who are going to present, 1 in 10 people who are going to represent with self-harm, repeat self-harm, do so within 5 days of presentation. 72 hours aligns with the follow-up periods, the suggested follow-up periods in mental health services. So swift aftercare is important. And intervention. So you're treating, if you like, the underlying needs, the underlying conditions that led to the self-harm, but also specific psychological interventions for self-harm, which we've been really poor at. Traditionally in the UK. We know that things like CBT, problem-solving therapy, interpersonal therapy, specifically tailored for self-harm, can result in a 40 to 50% reduction in repetition. It's cost effective, will end up saving the NHS money, but we don't yet have a kind of a systemic way of intervening after self-harm. Suicide prevention strategy, there's loads in there, many of the kind of stuff that's also in the WHO things. Here are some of the new things that you will have heard about. So there's all the stuff about online safety, new risks that didn't appear before that we've become more aware of, like gambling. Think about risk. I'll talk about this in a second. Mental health support in schools, really important. And there was also some funding for charities. Thinking about data and surveillance and new suicide methods are really something we worry about, and we kind of think about because they can lead to increases. Thinking about how we get more timely suicide, and also taking care of our staff. So many people working in services, thinking about the mental health impact on those people, thinking about even suicide rates in those people. And one of the things that was adopted by the last government was thinking about how any policies will impact on mental health. That's all of this has been ratified by the new government, but I think it's a difficult. I imagine it's a difficult job governing and thinking about conflicting priorities, but certainly thinking about the mental health impact on some of the economic measures that are going to be introduced. The other bit of evidence is some of the stuff we produced from the National Confidential Enquiry. So this is more specific to mental health services. Now, I know some of you working in mental health services. So this is one of our favourite slides, summarising about 2 decades of research in a single slide. Some of the things we know make mental health services safer. So crisis support, involving families, the role of drug and alcohol misuse, think about inpatient care and follow-up. Some of the things we've talked about, some of these things pertinent across the country, not just in the north. Also, kind of 24-hour kind of crisis teams, but also things like staff turnover. So it's the role of our staff ensuring the safety of patients, of service users. We know that areas which have stable workforces, happy workforces, are safer organisations. So it's not just the system, it's also our staff. Just looking at time. Here are some of the things that aren't helpful that I think we need to kind of be mindful of. We've got very variable services for self-harm. This is across the country, just showing the proportion of people who get assessed in different hospitals. So this is nationwide, not just the north, from a few years ago, but we've got no indication that this has changed. So, proportions, everyone's supposed to get an assessment, but the proportions varying from about a fifth to, nearly 80%. So there's huge variability of services. That's not helpful. Care like this, this is a kind of service user account. That's not helpful. I'll leave you to read that for a second. And as well as variable care, it's fragmented care. So many of you working in mental health will be familiar with this, people getting kind of referred from bit to bit of the system. There's a Samaritan's report published on that, called Pushed from Pillar to Post. So that sums it up very nicely. Talked a little bit about risk. One of the things we've talked a lot about recently in our unit and more widely is the low risk paradox. So it's just something that won't be a surprise to some of you, maybe a big surprise to others. So the National Confidential Enquiry, we collect data on all patients in the UK who have died by suicide. We got data going back to 1996, but it's just looking at the most recent tranche of data. And what we find is for patients who die by suicide, we ask clinicians, what was their risk of suicide? What did you think their risk was the last time you saw them? And I think, it's a very surprising finding when we first started. And 80% of patients who went on to die by suicide, often just a week later, so in about half of cases a week later, in 80% people rated them as at low or no risk. Okay, there are many reasons for that. The fact that risk changes perhaps, but it's more this kind of downgrading of risk that appears in clinical services, and the fact that actually these broad categorizations of risks aren't helpful, don't account for the full picture, and lead to large numbers of people being excluded. So, we're working with services to move away from this low, medium, high categorization of suicide risk, which those of us in mental health services have been obsessed by for many, many years. And it just to kind of let you know, the situation is no better in the north. In fact, it's slightly worse. The low risk paradox is slightly worse. So, 85%, 83% of patients rated as at low or no risk prior to suicide. So I'm coming up to about half hour now, and I'm on the last bit of my talk. So thinking about implementation, and this is really important. All the research, us researchers, we love research, but all the research in the world is no good unless it leads to change. And we're lucky enough. We've been going a long time. We've been able to show how our work has had impacts. Some of the recommendations we make in inquiries on the inquiry we implement in mental health services. A couple of papers here which show the effects that those have had. 200 to 300 lives saved per year if you extrapolate it up. The idea there's an interaction between the changes you make in services and the type of services. So actually, services with a stable workforce, if you make the changes there, they have more of an impact than if you make them in an unstable organization. So it's the changes, it's the context, and we can show in mental health services that made a difference. But this is our latest kind of bit of work, and it's not a kind of traditional kind of research study in a way. It's thinking about some national quality improvement work we've done with services over the last kind of 7 years across England, and there's three different bits. One's focused on suicide, so it's working with areas to think about how they reduce suicide. So the if you like, the interventions are suggested by them. It's about you go away and doing it, and the quality improvement bit is you implement changes, you see what effect they have, and you adapt your approach. So it's rapid implementation, rapid change, kind of agile systems, and seeing what difference that makes. So one of them was around suicide. One of them was focused on self-harm, so more specifically interventions for self-harm. And one of them was focused on improving the quality of assessments after self-harm. So there's the paper there. I mean, with this kind of stuff, it's difficult to show an effect on overall kind of suicide rates. So looking at suicide rates in England, yeah, we couldn't see much of an effect. But obviously, there's loads of different stuff going on here. There's changes to the way suicide's defined. There's the COVID pandemic. There's the economic turmoil. So, it's difficult to show an effect. And we didn't see anything very much in terms of overall rates. We did see young people were a bit of a focus of this program. We did see the long term rise of suicide in young people kind of tailed off around 2018 when these programs started coming up to kind of speed. And the other thing we did notice, again, it's weak data, it's observational, this isn't randomized in any way, but it is national data. The patient suicide rate fell. So these are users of mental health services, taking into account the number of people in contact with mental health services. That's a rate. It did notice a fall in patient suicide rate, and a lot of this was clinically focused. So that's certainly plausible. And we also saw a fall in self-harm admissions. Now, not everyone, but only about 50% of people are admitted to hospital after self-harm of those who present to the emergency department, and many people don't even present to the emergency department. They don't seek healthcare. So you have to, this comes with a bit of a caveat, but a fall in self-harm admissions, this might simply be a reduction in admission practices, but it in some sense just triangulates with some of the other data. But more important than that, almost the outcome data. Obviously, we have to have that outcome data. We have to collect it. And in terms of mental health innovation, it's a big gap, really. We're really great at innovating in mental health services and health services. Quite often, we don't measure the effect of our changes. So the measurement's really important. But actually, for me and for many colleagues, what was almost more impressive than the possible effect on outcomes was kind of galvanizing the activity, the kind of enthusiasm around kind of suicide prevention and some of the activity that generated. So there's examples of these on our website. So in Kent and Medway, there's a big campaign about thinking about awareness raising in men, particularly middle-aged men who have the highest suicide rates. In other areas, it's a kind of specific focus on care pathways. So safety planning is something, a specific intervention for use after people have self-harmed or are suicidal. And it led to other innovations as well. So local systems of trying to collect more timely data of suicide. And that was really important, actually, because this happened in 2018, 2019. When the pandemic came along in 2020, we were being told that suicide rates would increase. The official national data was, if you like, a year and a half behind as it always is. But some of the real-time systems that came up as a result of this program were able to say that rates of suicide didn't rise and in many places actually fell during the pandemic. So lots of kind of really useful activity, and much of this work is still going on. The other thing we're continuing with our implementation work is this idea that we move away from these reductionist approach to risk, the high, medium, low, the tick box exercise. So we're working, our current quality improvement, our current implementation work is focused on that. And the most reassuring, sometimes mental health services get really nervous when you say, look, forget about low, medium, and high risk of suicide. What are we going to do? What are we going to do? But the most reassuring things I can show them is the fact that people who have been there, done that already. So a couple of areas, Sussex and Borders Partnership, Avon and Wiltshire, and all these slides will be available. And there are video links to people saying, like, this is how we did it. And the other thing that's happened recently in terms of the risk assessment and how we move away from those very reductionist approaches, something that's more personalised is this new guidance from NHS England. Again, I'll include the link. So I've talked a little bit about suicide data, the north-south divide, the great variation. Talked about the really important role of inequalities. Talked about the evidence base for prevention. So, there's quite a lot we know about what helps prevent suicide, both in and out of clinical services. But, really we need to implement what we know. So just lastly, just a quick summary. Suicide rates are higher in the north versus the rest of England. That won't be a surprise to you. Health and social care needs vary. And, you remember that slide about the different preventative focus. Inequalities affect both suicide rates, but also the help seeking, and they affect those other causes of death as well, particularly drugs and alcohol. And remember, those effects may be long lasting. That slide on social mobility. Economic and welfare policy, major impact on suicide in terms of, the North's agenda. If we're thinking about economic regeneration, that's going to be good for reducing suicide rates. Clinical and public health interventions are very kind of helpful. There's lots of things we can do in clinical services and beyond. We've got to take care of this kind of fragmented services, and this any kind of reductionist approach. Risk assessment isn't just one. The idea that AI is going to be a panacea, Dan and I have talked about that many times, is another. But we've got to implement what we know, and it's not just about the outcomes, although they're important. It also galvanizes activity. And the last thing I always like to do is just put up a slide of some of the colleagues we've got working on this here at the University of Manchester. You can never get everyone on a photograph, but here are some of them who do all the hard work, and I just get to present it. So thank you very much. I shall, if I can, stop sharing. There we go. Stop sharing. Right.
Thank you so much, Nav. That was it was inspiring. Thank you very much for coming in and sharing your time and expertise with us.